Standard Occlusion Theory for TMD. I am Sotokawa, a dentist practicing in Morioka City, Japan. This theme covers the occlusion theory essential for treating temporomandibular joint disorders, organized into the following 24 topics. This time, I will explain the 17th topic. Anterior Guidance. 17. Anterior Guidance. Contents. 1. What is anterior guidance? 2. Individual variation in anterior guidance. 3. The significance of anterior guidance. 4. Determining maxillary anterior tooth morphology. 1 stage, 2 stage, 3 stage, 4 stage, final stage. 5. Guidelines for maxillary anterior tooth morphology for aesthetic form. A. Midline. B. Incisor morphology. C. Gingival morphology. D. Canine inclination. E. Canine morphology. 6. Key points of anterior guidance. 1. What is anterior guidance? Jisai demonstrated that anterior guidance holds equal importance to condylar guidance as a guide for mandibular movement. Dawson explains this in Chapter 17 of Functional Occlusion, titled, The Relationship Between Anterior Guidance and Smile Design. Theories concerning anterior guidance continue to be actively debated and are progressing and evolving. As a result, anterior guidance is now recognized as one of the most crucial elements in aesthetic dentistry. 2. Individual variation in anterior guidance. Dawson illustrates 3 distinct anterior guidance patterns in the right illustration. As such, anterior guidance exhibits significant individual variation, making its setting for patients inherently complex. Furthermore, anterior guidance must harmonize with functional movement limits. Additionally, anterior guidance is a crucial factor in aesthetics. Therefore, establishing anterior guidance requires the development of multifaceted theories addressing individual variation, functional harmony, and aesthetics. 3. The significance of anterior guidance. When reconstructing occlusion, anterior guidance becomes a crucial factor following centric relation. The illustration on the right shows that as the mandible moves from centric relation to a mandibular protrusive position, the continued contact of the anterior teeth causes the molars to separate, thereby protecting them. This role of the anterior teeth is vital. Molars not protected by the anterior teeth will inevitably experience significant stress in the future. Meanwhile, anterior guidance is established through contact between the maxillary and mandibular anterior teeth. Consequently, the morphology of the anterior region strongly influences anterior guidance. In other words, anterior guidance is key to the aesthetics of the anterior region. 4. Determining maxillary anterior tooth morphology. First stage. The morphology of the maxillary anterior teeth is determined through 5 stages. The first stage is the red line section indicated by the arrow in the right illustration. This portion of the lingual surface of the maxillary anterior teeth must be shaped such that, during centric occlusion, the incisal edge of the mandibular anterior teeth achieves a distinct stop on the lingual surface of the maxillary anterior teeth. Second stage. The second stage of determining maxillary incisor morphology involves defining part 2 in the right illustration above, specifically the upper half of the labial surface. This area can be precisely set using the diagnostic model. As shown in the lower right illustration, the upper half of the labial surface must lie on the extension of the labial aspect of the alveolar ridge, with no curvature from the ridge to the tooth surface. To facilitate this determination, the diagnostic model must accurately capture the entire labial aspect of the alveolar ridge. Third stage. The third stage of maxillary anterior tooth morphology determination establishes the shape of the lower half of the labial surface, indicated as section 3 in the right illustration. This surface constitutes the second distinct surface, separate from the one established in the second stage. Close attention must be paid to ensure the upper and lower lips can make firm contact with this surface as a guide. When modifying this surface, the procedure requires first estimating the morphology using a diagnostic wax-up on the model, then placing a provisional restoration on the patient, and finally adjusting and completing that surface. Fourth stage. The fourth stage of maxillary anterior tooth morphology determination establishes the position and shape of the incisal edge, as shown in part 4 of the right-hand illustration. The incisal edge of the incisors must follow the inner lip contour when the patient smiles gently, as shown in the middle right illustration. This incisal edge position also represents the ideal relationship between the anterior teeth and the lower lip for natural speech, as depicted in the bottom right illustration. Further refinement of the precise position and morphology can be achieved by having the patient speak while wearing a provisional restoration. Final stage. In the fifth stage of maxillary anterior tooth form determination, the morphology of the area labeled A5 in the right illustration is established. Previously, the starting point 1 and terminal point 4 of functional mandibular movement were determined. That is, the region between 1 and 4 constitutes the portion forming the functional movement trajectory of anterior guidance. The morphology of this area is determined by harmonizing anterior guidance with the functional range of mandibular movement. To achieve this harmony, the following 5 steps are necessary. Step 1. Establishing the centric stop. Step 2. Expanding the centric stop. Step 3. Determining the incisal edge position. Step 4. Establishing group function during linear anterior movement. Step 5. Establishing ideal lateral movement with distributed load on the anterior teeth. Each step will be explained. Step 1. Establishing the centric stop. As shown in the photo on the right, we construct adjusted centric stops for all anterior teeth. Step 2. Expanding the centric stop. When the habitual occlusal plane is positioned anterior to the centric relation, extend the centric stop anteriorly at the same vertical dimension of occlusion. Long centric. Step 3. Determining the incisal edge position. The position of the incisal edge, as shown in the photo on the right, is second in importance only to maintaining centric occlusion. If the anterior teeth are appropriate and do not require morphological alteration, the incisal edge position should be preserved. When restoring the incisal edge with a prosthesis, a provisional restoration should be placed for the patient to wear. The final form should be determined only after the patient accepts its comfort and aesthetics. Step 4. Establishing group function during linear anterior movement. It is a mistake to believe that all oral conditions should adopt group function during lateral movement. This is just as erroneous as insisting that all occlusions should be canine-guided. In dentition, where highly stable lateral movement is achieved with canine-only guidance, there is no need to alter this occlusal relationship. However, when canines exhibit significant mobility, advanced wear, or appear to be losing support from the periodontal tissues, transitioning to group function with other anterior teeth can reduce the burden on the canines and lessen their wear. While there are benefits to changing canine guidance to group function, conversely, there are no clear advantages to changing group function to canine guidance. Step 5. Establishing ideal lateral movement with distributed load on the anterior teeth. The final determining factor for the basic morphology of the anterior teeth is the prominence from the central stop 6 in the right illustration to the gingival margin. While this is a simple decision, errors in this morphology can interfere with the pronunciation of T, D, or S sounds, where the tongue positions itself to contact this area. A sharp ledge must be avoided. 5. Guidelines for maxillary anterior tooth morphology for aesthetic form. By this stage, the functional and anatomical boundaries have been established. In most cases, the diagnostic wax-up approximates the ideal morphology. Therefore, significant modifications are not required. However, minor morphological adjustments via the provisional restoration are necessary to optimize the labial contour and incisal edge position. When aesthetic concerns necessitate morphological modification, the following 5 guidelines are applied. A. Midline. B. Incisor morphology. C. Gingival morphology. D. Canine inclination. E. Canine morphology. Each is explained below. A. Midline. The midline should always be vertical, regardless of the slope of the cut edge. B. Incisor morphology. The incisal edge contour can be associated with a circle whose diameter corresponds to the tooth width. As shown in the right photograph, the mesial contour corresponds to a circle with a diameter equal to 1/3 of the tooth width, while the distal contour corresponds to a circle with a diameter equal to 2/3 of the tooth width. For lateral incisors, the mesial contour corresponds to a circle with a diameter equal to 2/3 of the tooth width, and the distal contour corresponds to a circle with a diameter equal to 3/3 of the tooth width. This ratio serves as a guide when shaping the morphology of anterior teeth. C. Gingival morphology. As shown in the photo on the right, the gingival morphology is triangular with the apex slightly directed distally. The height varies, with the central incisor being slightly higher than the lateral incisor. D. Canine inclination. As shown in the photo on the right, the canine inclination tilts inward in the frontal view. In the lateral view, the canine should be positioned vertically to maintain optimal aesthetics. D. Canine inclination. As shown in the photo on the right, the canine inclination tilts inward in the frontal view. In the lateral view, the canine should be positioned vertically to maintain optimal aesthetics. 6. Key points of anterior guidance. To achieve optimal stability, satisfaction, and functionality, the anterior region must exhibit harmony in the following aspects. Harmony with the neutral zone. Harmony with the lips. Harmony with pronunciation. Harmony with the centric relation. Harmony with the functional range of motion. Meeting these conditions leads to tooth positions and forms that are harmonized with the functional anatomical standards that produce the most natural aesthetics. Aesthetic dentistry and anterior guidance may be among the most complex and challenging fields within dentistry. Standard occlusion theory for TMD. 17. Anterior guidance is now complete. If you enjoyed this topic, please click the like button. If you have any questions or concerns, please write them in the public comment section below. The next topic is the 18. Long centric.